So hello everyone, I'm Dr. Ayush Pandey and welcome to this another interesting topic or course of the pain medicine. So in the last couple of sessions, we have discussed about the analgesics, opioids, non-opioids used in pain management. Now in this session, we'll be discussing about the adjuvant role in the pain management. So adjuvants, of course, are an integral component. So what exactly are the adjuvants? What are the classification of the adjuvants and how they play a role in the management of the pain we'll be discussing in this. So we'll be reviewing the different forms of adjuvants or co-analgesic medications, understanding the adult dosing for each of the medications and learn when to utilize them and when to take role of it or when to actually use it apart from the main opioids or non-opioids. And again, after the utilization part of it or learning when to utilize them, we'll be seeing the potential side effects which are being associated with the adjuvants. So basic principles, of course, we have discussed in the very first session of the physiology of the pain transmissions, which we have talked about, understanding the advantages and disadvantages of the various agents that are being used in the management of chronic pain and understanding the use of other modalities that are being used in pain management. So this is the, of course, pain ladder in the, again, in the previous sessions, we have discussed the 3-step analgesic ladder, which has been given by the World Health Organization of the pain. So we have 1, 2, and 3, that is the first, second, and third step. So in the first step or the first layer of this pain management, the role of non-opioids and the adjuvants, again, plus minus role. In the second stage, opioid for the treatment of mild to moderate pain, along with non-opioid plus minus adjuvants. And in the third stage, opioid for the moderate to severe pain, the role of non-opioid along with plus minus role of adjuvant. So if you can see this, on a persistent increase of pain from first to 3, there is the role of adjuvant is there at each and every step of the analgesic ladder. So adjuvants are an integral component. Now, when we talk about the overall definition of these adjuvants, what are these adjuvants? What do you mean by it, or what are these adjuvant analgesics? So they are also referred to as co-analgesics. They are medicines that are not primarily used for analgesia. They are medicines that are administered alone or with NSAIDs or opioids. Why? To enhance the analgesic activity of the NSAIDs or opioids, have independent analgesic activity for certain pain types like neuropathic pain and may counteract the side effects of NSAIDs or opioids. So these are the whole and sole goal of the adjuvant analgesics or co-analgesics which is being there. And this has been, again, if you want to read the complete detailed article and very beautiful article that has been published, that using opioids to manage pain in the APCA journal of 2010, edited, the second version published in 2012. So the role of adjuvants has been, indicated from time to time. So the adjuvants that target the neuropathic pain may be particularly important. Why? Because such pain may be difficult to treat with opioids alone. So adjuvants are also useful for other pain types that are sensitive to opioids. And what are those pain? Like bone pain, smooth or skeletal muscle spasm, or the pain that is being related to the anxiety. So these are the various adjuvants. These are the various, their role, and the pain that are being sensitive to the opioid use, bone pain, muscle, smooth muscle or skeletal muscle spasm, they are being played an important role in this. Now coming to the first category of, adjuvants, we must say, so anticonvulsants used for neuropathic pain. And again, what are the various anticonvulsants? If we talk about, we have which are being used. So clonazepam, adults dose of 0.5 mg to 2 mg OD. Then you have carbamazepine in a dose of 100 mg BD. And this dose can be escalated or titrated up to 800 mg BD. The third is the sodium valproate, adult dose of 200 mg to 1.2 gram OD. Gabapentin, adults, you start with 300 mg bedtime, and then titration of the dose maybe up to every 2 or 3 days can be done. And it is given in a dose of 300 mg BD than given TID. So until effective or side effects occur, The usual effective dose is generally 300 to 600 mg TID, but maximum dose of gabapentin can be given up to 1200 mg TID. But again, the dose of this gabapentin has to be titrated or, accordingly adjusted if the patient is of a patient of renal efficiency, kidney injury, acute or chronic kidney disease. So the dose has to be accordingly titrated or decreased. So use phenytoin and carbamazepine with caution. Why? Because of the rapid metabolization of drugs metabolized in the liver and because of the potential drug interactions this drug can have. So the side effects can be like drowsiness, loss of muscle coordination that is known as ataxia, and blurring of vision can also be there. Now coming to the second, that is the antispasmodics. So antispasmodics for the muscle spasm and specifically for the colically abdominal pain or renal colic has been used. And the most important of this is, the trade name or the very common brand name which is being there, or the generic name is Buscopan, that is a hyoscine butyl bromide. So the component or the generic component. So you give 10 mg TID, the Buscopan dose, and it can be increased to even 40 mg TID dose. But again, the side effect of Buscopan is it can cause nausea, it can cause dry mouth, or even it can cause constipation. So antispasmodics, that is the hyoscine butyl bromide, Buscopan, and then you have the anticonvulsants like clonazepam, carbamazepine, sodium valproate, gabapentin. Again, muscle relaxants again. Now the third is the muscle relaxant. So these drugs are used for which category? These are used for skeletal muscle spasm and are used to treat anxiety related pain. So the classification of it is diazepam, 5 mg given in a dose of 2 to 3 times a day. Lorazepam given in a dose of 0.5 to 2 mg, oral or IV every 3 to 6 hours. But the side effect of this diazepam and lorazepam can be, it can cause drowsiness or even it can cause ataxia. So 5 mg TID, diazepam, maybe twice or TID, and a lorazepam is 0.5 to 2 mg oral or IV every 3 to 6 hours. Again, short acting diazepam, lorazepam, even if you perform any kind of OPD procedures, any kind of daycare procedures, diazepam, lorazepam can be given accordingly for the relieving this anxiety related pain which is being there. So of course, if we talk about the, non-opioid adjuvant analgesics, non-opioids, they are non-opioids, but they have an analgesic efficacy. They increased or they, accentuate the dose of the analgesics that has been given. And that's why they call it as a adjuvant. So something that is being added up or adding up to the effect of the analgesia is the adjuvant analgesic. So primary, of course, used to treat neuropathic pain syndromes, but again, it is also effective in the management of nociceptive pain when used as adjuvant to other medications. So we have talked in very much detail about the nociceptive pain in the previous sessions, and we have, in the first two classes, we have dealt in detail about the nociceptive receptors, mechanical, chemical, thermal receptors, and the various kinds of pain and the nociceptive pain. So of course, if we talk about, the step of the ladder, WHO analgesic ladder. So NSAIDs, of course, antidepressants, anticonvulsants, corticosteroids, bisphosphonates, anesthetics, and N-methyl D-aspartate antagonists, that is the NMDA antagonist receptors can be there. And these are the various classification of adjuvant analgesics which we have. Acetaminophen and paracetamol, again NZ. So again, mechanism of action and clear, but of course, the inhibition of the COX pathway, that is the cyclooxygenase pathway in the CNS, is the primary mechanism of action. And when we talked about the analgesics used in treatment of pain management, we have talked about the detail of the pathway of the LOX-COX pathway, which are used in the pain management. So acetaminophen can cause liver damage, but again, if the dose exceed 4 times the normal dose. So, but risk of hepatic injury is increased in patients who already have a pre-existing liver damage like alcoholic hepatitis or cirrhosis. So But again, if the patient is maybe a renal patient also, so acetaminophen has also been shown to cause renal damage also. So potential, of course, a hepatic injury, a potential hepatotoxic drug, acetaminophen, but again, the risk of causing injury to the kidneys or renal damage is being also there with the use of acetaminophen. So mechanism of action of COX to decrease the prostaglandin synthesis, yes. They can also have a central action at the level of spinal cord. Tolerance and physical dependencies is not seen, which were being seen with opioids. So can be associated with end organ toxicity. Coming to the neuropathic pain syndromes, and we have been talking about the adjuvant analgesics. So the primary role or the primary overall treatment medication which are being used primarily to treat neuropathic pain syndromes, the adjuvant analgesics. So used in the treatment of or used as an adjuvant analgesic in trigeminal neuralgia, post-herpetic neuralgia, diabetic neuropathy, phantom limb pain. Yes, if there is a no limb, if there is a loss of complete hand, and the patient is experiencing some tingling numbness effect, the pain which is being even felt due to the absence of complete absence or not presence of the organ. Central post-stroke due to the damage to the thalamus, syringomyelic pain, and sympathetically maintained pain syndrome. So chemotherapy-induced neuropathy, diabetic neuropathy, post-herpetic neuralgia, trigeminal neuralgia, and the various neuropathic pain syndromes where the adjuvant analgesics can play a role. Now, tricyclic antidepressants, of course. So how they act or what is the mechanism of action of tricyclic antidepressants? So they inhibit the reuptake of norepinephrine and serotonin, and where these reuptake is being inhibited in the nerve endings in the spinal cord and brain, and therefore they provide the relief. NMDA, neuromuscular receptor, which we have discussed, this NMDA receptor antagonist. So it is a NMDA antagonist. Antidepressants, now coming to the, one more class or one more type of antidepressants, tricyclic antidepressants. So of course, used for neuropathic pain, presenting as burning and abdominal sensations. And these abnormal sensations are known as dysesthesia. So if we talk about the adult dose of amitriptyline, that is a tricyclic antidepressants, in adults it is given in a dose of 10 to 75 milligram or 0.5 to 2 mg per kg at night, and then again you slowly increase the dose as it is being needed. Commonly start at 12.5 mg at night and then increase to BD as needed, and response effectively can be seen in within 4 to 5 days. But again, even after giving the amitriptyline, you are not seeing any potential response, no effect is being there after the 1 week, then you can basically think of switching the drug or stopping the drug accordingly. The side effects, if we talk about the antidepressants, the side effects include dry mouth, yes, drowsiness. So that's why it is used and has to be used with caution in the elderly, because it increases the risk of falls. Used with cautions in those who have cardiac disease. Why? Because of the orthostatic hypertension. Nortriptyline can be better tolerated, and it has been also seen that it is better tolerated than amitriptyline. So if we talk about the classifications of tricyclic antidepressants, the suffix like the amitriptyline, so triptyline or imipramine or clomipramine. So ipramine and triptyline suffixes. So based on the ipramine and triptyline, you have decipramine on the ipramine group, clomipramine, imipramine. So decipramine for the depression with fewer side effects, clomipramine for obsessive compulsive disorders, imipramine can be used for bedwetting even in children group, amitriptyline for depression and chronic pain, nortriptyline for the less hypotension effects than the other tricyclic antidepressants, and protriptyline used for depression. So tertiary amines and secondary amines. So in tertiary amines, you have amitriptyline, you have doxepin, you have imipramine and clomipramine. In secondary amines, you have decipramine and nortriptyline. Serotonergic agents. So antidepressants are being classified into reversible MAO inhibitors, that is the moclobemide, selective serotonin reactive inhibitor, one of the very famous and one of the also most commonly used class of antidepressants. So you have fluoxetine, fluoxamine, paroxetine, sertraline, citalopram, escitalopram, and dapagliflozin. Then you have atypical antidepressants. You have mirtazapine, bupropion, mianserin, trazodone. Then tricyclic antidepressants. You have noradrenaline plus 5-HT reuptake inhibitor, and then predominantly noradrenaline reuptake inhibitor. So predominantly NA reuptake inhibitors are desipramine, nortriptyline, and amoxicillin. But noradrenaline and 5-HT reuptake inhibitors are imipramine, amitriptyline, trimipramine, doxepin, doethiapine, and clomipramine. So this is the various classifications of antidepressant group. SSRIs that we talked about, the selective serotonin reactive inhibitors. So generic name, again brand name most commonly. So citalopram, Celexa by the common brand name which is being available, duloxetine, Cymbalta, escitalopram, Lexapro, fluoxetine, Prozac, Reconcile, paroxetine, Paxil, Paxeva, sertraline, Zoloft, Valaxifenine, that is the Effexor. So these are the various generic names and the accordingly associated brand names which are being linked to the SSRI and SNRI, which are being there in the market. So if we talk about the tricyclic antidepressants or the antidepressants, used for analgesia, yes, used for depression, used for insomnia, and even some mild amount of itching or pruritus, the role can be seen accordingly. So mechanism of action, which we have discussed, inhibition of the neurotransmitter reuptake, that is the serotonin, norepinephrine and dopamine. Only tricyclic antidepressants have analgesic properties, that is independent of their antidepressant activity. So tricyclic antidepressants have analgesic properties, but again, only tricyclic antidepressants out of this antidepressant class, their analgesic properties is being independent of their antidepressant activity. There are side effects which are being related to the antidepressants and we talked about. So if we commonly want to remember it by the mnemonic, you have TCAS mnemonic, that is the tachycardia, cardiac effects, anticholinergic effects, and sexual dysfunction. So the 3 C's toxicities are, that is the cardiac effects that is being associated are cardiotoxicity, convulsions, and coma. That is the 3 C's. So a person with depression tries to be candid. So what are the drugs? If you remember by the name of candid, clomipramine, amitriptyline, nortriptyline, doxepin, imipramine, and desipramine. So most TCAs, as we know, end with either triptyline or amine, but this is the most common side effects which are being linked to the antidepressant cause. Again, long-term use of TCAs is being associated with a 2.2 relative risk of myocardial infarction and 1.7-fold increase in the mortality versus the placebo or use of SSRIs. So that's why the cardiac side effects like cardiotoxicity can be seen, increasing the risk with TCAs to almost 2.2 of the myocardial infarction. Anti-epileptic drugs. So what is the mechanism of anti-epileptic drugs, which is the another classification? So slow recovery of voltage-gated sodium channels from depolarizations, and the common classification or the common drugs are the carbamazepine and the phenytoin. So indirect or direct enhancement of the inhibitory GABA, that is the GABA aminobutyric acid neurotransmission, and the drugs are valproic acid and the ticabin. Inhibition of the excitatory glutaminergic neurotransmitter, you have a lamotrigine. So these are the various mechanisms where you inhibit the excitatory neurotransmitters. You have a lamotrigine, indirect or direct enhancement of the inhibitory GABA neurotransmission, that is the valproic acid and the ticabine, and slow recovery of the voltage gated sodium channels that have been lighted up into the depolarization. You have carbamazepine and the phenytoin. Mechanism of action of anti-epileptic drugs. They block the voltage-gated calcium channels. And the examples are gabapentin and pregabalin. Yes. Carbonic anhydrase inhibitors. Topiramate, carbonic anhydrase inhibition. So topiramate and zonisamide. So if we talk about the overall classifications, anti-epileptic, barbiturate, you have phenobarbital, hydantoin, phenytoin, fosphenytoin, succinamide, ethosuccinamide, deoxybarbiturate, primodon, immunostilbane, carbamazepine, oxcarbamazepine, aliphatic carboxylic acid, valproate sodium, divalproex, benzodiazepines, clonazepam, diazepam, lorazepam, phenyltrazine, lamotrigine, newer drugs like topiramate, levetiracetam, vigabatrin, tigabine, lacosamide, and cyclical GABA analogs like gabapentin and pregabalin. So this is the complete classification of the anti-epileptic drugs. So molecular targets for the anti-epileptic drugs, and this is the overall targeted zone when we talk about the anti-epileptic drugs. So you have sodium channel target or slow recovery, which we talked about. So sodium channels is being targeted by the list of these drugs like phenytoin, carbamazepine, lamotrigine, fosphenytoin, zonisamide. Calcium channels, ethosuccinamide, mixed with valproate, felbamate, topiramate. GABA receptor target, phenobarbital, primidone, diazepam, clonazepam, clorazepate. GABA transporters, you have ticabine. GABA transaminase targets are the vigabatrin. And some unknown, maybe molecular targets, which was being given back date into the 1993 and 1999, was with gabapentin and levetiracetam. So these are the newer classifications, and we have discussed the whole and soul classification of the AEDs, pregabalin, and very commonly used neuropathic pain. Also, pregabalin is being given. And again, you have lamotrigine, you have levetiracetam, topiramate, gabapentin. So for neural pain, for slip disc, sciatica pain, nerve pain, so this gabapentin, pregabalin are being commonly used. So with these drugs, you have to start with a low evening dose. And again, the titration of the drugs has to be slowly done over the period of 4 to 6 weeks. So gradual increase of the dose depending on the response. And they are typically effective at a higher doses which are being there. I'm so sorry. The various another some side effects can be like drowsiness, yes, dizziness, confusion, vesicular papular rash, ataxia, nausea, vomiting can be there. Aplastic anemia can be also there. Coming to the gabapentin, of course, post-herpetic neuralgia, established efficacy. So most common mistake is failure to titrate the effective doses. So this is the, one of the most common. So if how you will, titration of this gabapentin dose or accordingly you have to do. So start with a low dose as we talked about evening dose. Start with a low evening dose, 300 mg, nighttime, bedtime. Escalate it to BD dose of 300 mg and then it can go to 300 mg TID. So 100 to 300 mg per day over the next 2 weeks to target a dose of 1800 milligram. Continue titration over 2 more weeks to 3600 milligram if indicated for effect. So higher doses have also been successfully used in the patients. The advantages of pregabalin are it includes a pre-delectable absorption, not metabolized or protein bound, has a minimal drug-to-drug interactions, and multiple studies have demonstrated the effective pain relief and decreased sleep interference in the post-herpetic neuralgia treatment. So yes, very commonly used. If we talk about the doses of pregabalin, On the day 1 to 3, you start with a dose of 50 mg TID, and from 4 to 7 dose, escalate it to 100 mg TID. And thereafter, once you have escalated it to 100 mg TID, go to 200 mg TID and then taper the dose over the 7 days to discontinue or to stop the medications once your goal or your overall pain management has been accordingly done. Lamotrigine, of course, has demonstrated efficacy in trigeminal neuralgia. So if we talk about the dose of lamotrigine, you start with a 25 to 50 mg OD dose, increase to 50 mg per day per week until effective, or an arbitrary maximum dose, usually around 900 mg daily, has been done in 2 to 3 divided doses. So if we talk about patients weighing, if you look at the chart which is being there, the amount of mg of lamotrigine which has been used in the week. So patients weighing less than equal to 25 kg and taking valproate. In a week 1 to 2, 5 mg lamotrigine, 3 to 4, 10. So accordingly, the escalation has been done. And weighing greater than 25 kg, 10, 25, 50, 100. Less than equal to 25 kg and not taking valproate. So in the 1 to 2 weeks, 25 mg, 3 to 4 weeks, 50, 5 to 6, 100, 7 to 8, 200, and 9 to 16, 200 to 300. For patient weighing greater than 25 kg and not taking valproate, in 1 to 2 weeks, you give 50, 3 to 400, 5 to 6, 200, 7 to 8, 300, and then 9 to 16, 300 to 400 accordingly. Topiramate. So studies demonstrate the utility in management of cluster headache and diabetic neuropathy. Effective in a dose range of 200 to 400 mg daily in 2 divided doses, has been associated with weight loss. The various side effects of topiramate includes abnormal thinking, delusional and psychotic thinking, and kidney stones can also be there.